Greetings to all our NCLEX warriors. Today's video is all about pharmacology of immunizations, a must-know topic packed with critical vaccine knowledge that could make or break your NCLEX score. We are diving into 14 of the most important NCLEX-style questions that cover everything from live versus inactivated vaccines, age-specific schedules, safety during pregnancy, and even how vaccines play a role in cancer prevention. These are the exact kinds of questions that show up on the exam, and we are here to break them down so they finally make sense. And here's why you should stick around. This is not just a one-time session. We bring you brand new, high-yield NCLEX content every single day. If you are serious about passing the NCLEX and becoming a confident, knowledgeable nurse, then hit that subscribe button, stay till the end, and make us part of your daily NCLEX routine. This could be the game changer you have been looking for. Before we jump into today's question, ask yourself, are you fully prepared for the NCLEX? If not, our complete NCLEX review online course is here to help. You'll get 100 hours of animated content, 500 hours of expert lectures, 5,000 high-yield questions, 500 NGN-style case studies, and 15 full-length mock exams that simulate the real test. It also includes a full NCLEX ebook, all valid for 1 year. Right now, you can grab it at an unbeatable 70% off for a limited time. Thousands of students are already on the path to success. Click the link in the description and join them today. As we continue, we are stepping into the world of public health strategy, tracking how global travel and immunization efforts intersect to stop the spread of disease. This question is especially relevant in today's global world, where diseases can cross borders just as easily as people do. Get ready for question number 1. The nurse is leading a community health workshop on measles prevention and global travel. Which of the following statements best reflects current trends in how measles is most commonly contracted? Think carefully as we walk through your choices. Option A. Most adult cases of measles occur following incomplete childhood vaccination schedules. Option B. Individuals with chronic illness are more likely to acquire measles due to weakened immune systems. Option C. Measles exposure primarily happens in healthcare settings from undiagnosed carriers. Option D. A large proportion of measles cases are seen in unvaccinated travelers who acquire the infection internationally. Now, let us break this down and see which option best reflects the current global trend. The correct answer is Option D. A large proportion of measles cases are seen in unvaccinated travelers who acquire the infection internationally. Here is what makes this the best answer. Measles is still circulating in many parts of the world where vaccination rates remain low. According to the Centers for Disease Control and Prevention, most cases in the United States are imported by individuals who travel abroad without being immunized. When these unvaccinated travelers return home, they can spread the virus unknowingly, often before symptoms even appear. This has led to outbreaks in communities where immunization coverage is spotty. While incomplete childhood vaccinations may play a role in susceptibility, most current cases are not due to partial immunity. They are due to complete lack of vaccination. And while individuals with chronic illness are at greater risk for complications, they are not the primary population contracting or spreading the disease. Similarly, although healthcare settings can be points of transmission, they are not the most common sites of exposure. For NCLEX preparation, remember this key point. Measles prevention in international travel is essential, especially in those who are not yet vaccinated. Nurses must educate clients about pre-travel immunization and recognize the critical symptoms such as high fever, runny nose, red eyes, and the signature spreading rash. Also keep in mind that infants as young as 6 months who are traveling internationally should receive an early dose of the measles, mumps, and rubella vaccine, even though it will not count toward their regular schedule. Understanding these patterns will help you answer similar questions with confidence and reinforce your role in global public health as a nurse. Now that we have covered global health and travel-related infections, let us shift focus to routine pediatric care, specifically vaccine administration during infancy. This next question tests your knowledge on safe injection practices, a vital part of nursing care that you will definitely encounter both in the NCLEX and clinical settings. Get ready for question number 2. The nurse is preparing to administer an intramuscular vaccine to a 4-month-old infant during a routine well baby visit. Which anatomical site should the nurse choose to ensure optimal absorption and minimize the risk of complications? Think carefully here. This is not just about knowing anatomy, but about understanding which muscle groups are safest and most reliable for infants. Here are your options. Option A, the upper outer quadrant of the gluteal region, near the sciatic nerve. Option B, the anterolateral aspect of the thigh, in the mid-portion of the vastus lateralis muscle. Option C, the upper arm, approximately 2 inches below the acromion process. Option D, the lateral hip region between the greater trochanter and the anterior superior iliac spine. Now let us walk through this together and determine the most appropriate choice. The correct answer is option B, the anterolateral aspect of the thigh, in the mid portion of the vastus lateralis muscle. And here's why this makes the most clinical sense. This site, the vastus lateralis, is the most well-developed muscle in infants under 12 months of age and is easily accessible. More importantly, it is away from major nerves and blood vessels, making it the safest choice for intramuscular injections. When administering the vaccine, nurses should aim for the thickest part of the muscle, which is located in the middle third of the thigh, between the knee and the greater trochanter of the femur. Now, why are the other sites not appropriate? Option A, the upper outer gluteal area, also called the dorsogluteal site, is outdated and not recommended anymore, especially in infants, because of the high risk of injuring the sciatic nerve and the unreliable fat-to-muscle ratio, which may lead to subcutaneous rather than intramuscular delivery. Option C, the deltoid muscle, is just not developed enough in young infants to safely handle an injection and carries a risk of hitting the radial nerve. This site is better reserved for older children and adults. Option D, the ventrogluteal site, is a great option for children over 12 months and adults, but for infants it is not ideal due to underdeveloped muscle tissue and difficulty in landmarking. So, for the NCLEX, always associate the vastus lateralis muscle with safe and effective intramuscular injections in infants under 1 year. It is a high-yield, frequently tested topic that demonstrates both your clinical reasoning and your ability to provide safe care. We have now explored safe vaccine administration sites, so let us switch gears and talk about the vaccine schedule itself, something that every nurse must be able to confidently teach to parents. Immunization timing can be tricky, especially in the first year of life when multiple vaccines are due. So here comes question number 3, and it is all about understanding which vaccines are appropriate for infants before they reach 8 months of age. The nurse is educating the parent of a 6-month-old infant about the routine childhood immunization schedule. Which of the following vaccines is appropriately administered before the infant reaches 8 months of age? Time to think through each of these carefully, especially the timing. Here are your options. Option A, meningococcal conjugate vaccine. Option B, Haemophilus influenza E type B vaccine. Option C, hepatitis A vaccine. Option D, human papillomavirus vaccine. Now let us identify the correct answer based on the routine pediatric immunization timeline. The correct choice is option B, Haemophilus influenzae type B vaccine. Let me walk you through why this is correct. The Haemophilus influenzae type B vaccine, also known as HIB, is a key part of the infant vaccination schedule. The first dose is given at 2 months of age, with follow-ups at 4 months, and depending on the brand used, possibly at 6 months too. A booster is then given at 12 to 15 months. This vaccine is essential because it protects against several life-threatening bacterial infections in infants, such as epiglottitis, meningitis, pneumonia, and sepsis. Now let us examine the other options and see why they are not appropriate before 8 months of age. Option A, the meningococcal conjugate vaccine, is not given routinely to infants. It is reserved for children with certain high-risk medical conditions such as asplenia or complement deficiency, and the typical age to start this vaccine is 11 to 12 years. Option C, the hepatitis A vaccine, also does not fit the timeline. It is recommended for children beginning at 12 months of age, with a second dose 6 months after that. And option D, the human papillomavirus vaccine, is definitely not part of the infant series. It is administered starting at 9 years of age, with routine dosing at 11 to 12 years. So for NCLEX purposes, always match vaccines to the child's age. In infancy, you will see vaccines like HIB, diphtheria, tetanus pertussis, polio, pneumococcal, rotavirus, and hepatitis B. Vaccines like measles, mumps, and rubella or varicella come later, after the first year. Remembering this timeline will help you confidently answer immunization questions and educate parents effectively in your nursing practice. As we continue strengthening your foundation in pediatric nursing, this next question highlights one of the very first interventions a newborn receives, something that happens within the first days of life and is absolutely essential to long-term health. It is time for question number 4, where we focus on the immunization recommended for a full-term newborn just 4 days old. The nurse is assessing a full-term newborn who is 4 days old and has arrived for a routine wellness check. Based on the standard immunization schedule, which vaccine is recommended at this stage of the infant's life? Think about which vaccine is the earliest to be introduced right at birth. Here come your options. Option A, inactivated poliovirus vaccine. Option B, hepatitis B vaccine. Option C, measles, mumps, and rubella vaccine. Option D, pneumococcal conjugate vaccine. Now, let us find the right answer based on the current routine schedule. The correct response is option B, hepatitis B vaccine. And here is why this answer stands out. Hepatitis B is the only vaccine routinely given at birth. It is the first dose in a 3-part series, scheduled at birth, at 1 to 2 months, and then again at 6 to 18 months of age. For newborns, especially those born to mothers with unknown or positive hepatitis B surface antigen status, the first dose should be administered within the first 24 hours of life to prevent vertical transmission of the virus. If the vaccine was not given at the hospital, then it must be given during the earliest outpatient visit, such as this wellness check at 4 days of age. Now looking at the other options. Option A, the inactivated poliovirus vaccine, is part of the infant schedule, but the first dose is not due until 2 months of age. It is not appropriate for a 4-day-old infant. Option C, the measles, mumps, and rubella vaccine, is never given during the newborn period. It is administered starting at 12 months of age and again at 4 to 6 years, unless an early dose is specifically needed for international travel, which is not the case here. And option D, the pneumococcal conjugate vaccine, also begins at 2 months of age, not at birth. So when you see a question involving immunization for a newborn, your mind should go straight to hepatitis B. For the NCLEX, this is a frequently tested concept. Knowing which vaccines are given at what age helps demonstrate both safety and adherence to national immunization guidelines. Also remember, if the mother is known to be hepatitis B positive, the infant should receive hepatitis B immune globulin, along with the vaccine within 12 hours of birth. This combination is critical to prevent lifelong liver complications like cirrhosis or hepatocellular carcinoma. Keep that in your mental checklist when caring for newborns or reviewing vaccine schedules. Now shifting from newborn care to a high-stakes pediatric emergency, this next question focuses on a life-threatening condition that nurses must recognize immediately: epiglottitis. It is rare today, thanks to widespread vaccination, but knowing which vaccine prevents it is a must for both NCLEX success and clinical practice. So let us look at question number 5. The nurse is admitting a 3-year-old child with sudden onset of high fever, stridor, drooling, and respiratory distress. The healthcare provider suspects acute epiglottitis. Which vaccine most effectively prevents the bacterial infection commonly responsible for this condition? Think about the organism most frequently associated with epiglottitis and the vaccine that targets it. Here are your options. Option A, tetanus, diphtheria, and acellular pertussis vaccine. Option B, varicella vaccine. Option C, Haemophilus influenzae type B vaccine. Option D, pneumococcal conjugate vaccine. Now, let us zero in on the right choice based on the infection's cause. The correct answer is option C, Haemophilus influenzae type B vaccine. And here is why this is the best option. Haemophilus influenzae type B, or Hib, was once the leading cause of epiglottitis in children. This condition, which involves swelling of the epiglottis, can lead to sudden and complete airway obstruction. Before the Haemophilus influenzae type B vaccine was introduced, epiglottitis was a common pediatric emergency. Now, thanks to widespread vaccination beginning at 2 months of age, the incidence has dramatically declined in countries with good immunization coverage. The vaccine is typically given as a 3 or 4 dose series depending on the formulation, followed by a booster between 12 and 15 months. Now, let us briefly review why the other options are incorrect. Option A, the tetanus, diphtheria, and acellular pertussis vaccine, while important for preventing upper respiratory illnesses like whooping cough and diphtheria, does not prevent epiglottitis, because those conditions are caused by different pathogens. Option B, the varicella vaccine, protects against the varicella zoster virus, which causes chickenpox. It has no role in bacterial infections like Haemophilus influenzae type B vaccine. And option D, the pneumococcal conjugate vaccine, guards against Streptococcus pneumonia, another dangerous organism that causes pneumonia, otitis media, and meningitis. But again, it is not linked to epiglottitis. When preparing for the NCLEX, always associate sudden onset drooling, stridor, tripod positioning, and high fever in a young child with possible epiglottitis. Also remember, never attempt to inspect the throat with a tongue blade if epiglottitis is suspected. Doing so could trigger complete airway obstruction. The key takeaway is that Haemophilus influenzae type B vaccination is your frontline defense against this emergency. It not only protects against epiglottitis, but also against other invasive infections like meningitis and sepsis in infants and toddlers. Keep that in mind, because it is a textbook NCLEX question waiting to happen. As we continue building your clinical judgment, It is time to focus on preventive care strategies that protect our aging population. Vaccination does not stop after childhood. It becomes even more important as we age, especially when it comes to preventing life-threatening respiratory infections. That brings us to question number 6. The nurse is leading a community seminar for older adults on vaccine-preventable illnesses. Which of the following vaccines should the nurse specifically recommend for adults aged 65 and older to help prevent severe respiratory infection caused by Streptococcus pneumonia? Think about which vaccine targets this specific organism and is most commonly recommended in geriatric care. Here are your options. Option A, hepatitis, a vaccine. Option B, pneumococcal polysaccharide vaccine. Option C, rotavirus vaccine. Option D, diphtheria, tetanus, and a cellular pertussis vaccine. The correct answer is option B, pneumococcal polysaccharide vaccine. Now let us break down exactly why this is the right choice. Pneumococcal polysaccharide vaccine is specifically recommended for all adults aged 65 and older because it helps prevent invasive pneumococcal disease, conditions like pneumonia, meningitis, and bloodstream infections that can have devastating outcomes in older adults. If an individual received this vaccine before the age of 65, they should receive a second dose after they turn 65, provided that at least 5 years have passed since the first, when both pneumococcal conjugate vaccine and pneumococcal polysaccharide vaccine are indicated. The conjugate version is given first, followed by the polysaccharide version 1 year later. Now, let us consider why the other options are not appropriate. Option A, the hepatitis. A vaccine is intended for individuals at high risk such as international travelers or those with chronic liver disease. It is not a routine recommendation for older adults and does not target respiratory pathogens. Option C, the rotavirus vaccine, is only given to infants and is not approved or safe for use in adults. Option D, the diphtheria, tetanus, and a cellular pertussis vaccine, also known as DTaP, is only given to children under 7 years of age. Adults require a different formulation called tetanus, diphtheria, and a cellular pertussis vaccine, which is given as a booster every 10 years. For NCLEX, always associate pneumococcal polysaccharide vaccine with older adult care. It is part of a broader immunization strategy for individuals aged 65 and older, which also includes the annual influenza vaccine, the herpes zoster vaccine starting at age 50, and tetanus diphtheria pertussis boosters every 10 years. Knowing these age-specific recommendations will help you answer questions confidently and ensure your clients receive the best preventive care. Pause for a second. Let's talk about your NCLEX Prep. If you're looking for the most complete guide out there, this is it. 100 hours of animated NCLEX content, 500 hours of teaching, 5,000 high-yield questions, 500 NGN-style case study, and 15 exam-style mocks. Plus, you get a bonus NCLEX ebook and access for 1 full year. Get 70% off today. Limited time deal. The link's in the description. Join the thousands who are already passing. Before we dive into more complex scenarios, it is essential to master the fundamentals, like knowing which vaccine formulations are age-specific. This next question tests your ability to distinguish between pediatric and adult immunizations, a foundational skill every nurse must have. So let us go into question number 7. The nurse is reviewing vaccination schedules with a group of new parents. Which group of clients is appropriately scheduled to receive the diphtheria, tetanus, and a cellular pertussis vaccine? Read each choice carefully, because this is where understanding age-based formulations becomes critical. Here are your options. Option A, pregnant clients in the 3rd trimester of each pregnancy. Option B, adults aged 65 and older requiring a tetanus booster. Option C, children under the age of 7 as part of their primary immunization series. Option D, adolescents aged 11 to 12 during a routine wellness visit. The correct answer is option C, children under the age of 7 as part of their primary immunization series. Let me explain why this is the best choice. The diphtheria, tetanus, and a cellular pertussis vaccine used in children under 7 years of age is specifically formulated with higher concentrations of diphtheria and pertussis components. This version is designed to stimulate strong immunity in young children and is administered as a 5-dose series at 2 months, 4 months, 6 months, 15 to 18 months, and again at 4 to 6 years. Now, let us break down the other options. Option A, pregnant clients are given the adolescent and adult formulation, which is tetanus, diphtheria, and a cellular pertussis vaccine, not the pediatric version. It is given during the 3rd trimester of each pregnancy to pass protective antibodies to the baby and reduce the risk of pertussis in early infancy. Option B, adults age 65 and older should receive tetanus, diphtheria, and a cellular pertussis vaccine or tetanus and diphtheria vaccine every 10 years. The pediatric formulation is not appropriate for them due to the higher antigen load, which may lead to increased side effects. Option D, adolescents aged 11 to 12 also receive tetanus, diphtheria, and a cellular pertussis vaccine as a booster to maintain protection from their early childhood series. So when you are preparing for the NCLEX, remember this key distinction: diphtheria, tetanus, and a cellular pertussis vaccine is for children under 7, while tetanus, diphtheria, and a cellular pertussis vaccine is for older children, adults, and pregnant individuals. Matching the vaccine formulation to the age group is critical for both safe practice and acing the exam. Let us now shift into vaccine safety education, especially when it comes to addressing myths and misunderstandings that even nursing students may have about common immunizations. One such vaccine that often brings up questions is the measles, mumps, and rubella vaccine, especially in the context of pregnancy and breastfeeding. That takes us into question number 8. The nurse is providing an immunization education session to a group of nursing students. Which of the following statements by a student indicates an accurate understanding of the measles, mumps, and rubella vaccine? Now, as we go through the options, focus on both the timing and safety considerations of this live attenuated vaccine. Here are your choices. Option A. It is safe to administer the measles, mumps, and rubella vaccine to women who are breastfeeding. Option B. This vaccine should be administered during pregnancy to protect the fetus. Option C. The measles, mumps, and rubella vaccine must be avoided in anyone with a mild egg allergy. Option D. The measles, mumps, and rubella vaccine series begins at birth and includes 3 routine doses. The correct answer is Option A. It is safe to administer the measles, mumps, and rubella vaccine to women who are breastfeeding. And here is why that is the most accurate statement. Breastfeeding is not a contraindication for the measles, mumps, and rubella vaccine. In fact, the Centers for Disease Control and Prevention specifically states that live attenuated vaccines, including this one, can be safely given to lactating women. There is no evidence that the live virus from the vaccine is transmitted through breast milk or that it harms the infant in any way. Now, let us look at why the other statements are incorrect. Option B is not accurate because the measles, mumps, and rubella vaccine is contraindicated during pregnancy. Since it is a live vaccine, there is a theoretical risk of transmitting the virus to the fetus. While no actual harm has been consistently reported, it is strongly advised that women avoid pregnancy for at least 4 weeks after receiving the vaccine. Option C is also incorrect. Although this vaccine may contain trace amounts of egg protein, it has been shown to be safe even in individuals with severe egg allergies. There is no need to withhold the vaccine or take special precautions based on egg sensitivity. And option D is factually wrong because the measles, mumps, and rubella vaccine is a 2-dose series, not 3, and it does not start at birth. The first routine dose is administered between 12 to 15 months of age, and the second is given between 4 to 6 years. While a third dose may be considered during an outbreak, it is not part of the standard schedule. For NCLEX, always remember that the measles, mumps, and rubella vaccine is contraindicated in pregnancy but safe during breastfeeding, and that egg allergy is no longer considered a barrier to administration. Also note that routine dosing starts after the first birthday and includes just 2 doses. These are high-yield facts that often show up in immunization safety questions, and knowing them gives you a clinical edge both on the exam and in patient education. To continue sharpening your vaccine knowledge, let us now explore how different vaccines are classified based on how they are made. This next question is a must-know topic for both clinical practice and the NCLEX, especially when it comes to knowing which vaccines are safe for specific populations. That brings us to question number 9. During a staff and service on vaccine classifications, the nurse demonstrates accurate understanding by identifying which of the following as a live attenuated vaccine. Think carefully about which vaccines contain weakened but still active forms of the virus. Here are your options. Option A, varicella vaccine. Option B, hepatitis, a vaccine. Option C, human papillomavirus vaccine. Option D, meningococcal conjugate vaccine. The correct answer is Option A, varicella vaccine. Now let us break down why this is the correct choice. The varicella vaccine, used to prevent chickenpox, is a live attenuated vaccine. This means it contains a weakened form of the varicella zoster virus that still replicates in the body but does not cause disease in individuals with a healthy immune system. These types of vaccines tend to produce strong and long-lasting immunity, often with just 1 or 2 doses. However, because they involve a replicating virus, They are contraindicated in individuals who are pregnant or severely immunocompromised. Other examples of live attenuated vaccines include the measles, mumps, and rubella vaccine, the rotavirus vaccine, the yellow fever vaccine, the smallpox vaccine, and the intranasal formulation of the influenza vaccine. Now let us go over why the other options are incorrect. Option B, the hepatitis A vaccine, is an inactivated vaccine. It uses a virus that has been completely killed and cannot replicate in the body. These vaccines are safe for immunocompromised individuals, but usually require multiple doses and booster shots to maintain long-term protection. Option C, the human papillomavirus vaccine, is a recombinant subunit vaccine. It contains virus-like particles created using genetic engineering, which means it does not contain any live virus and cannot cause infection. This makes it both safe and effective, especially for preteens and adolescents. Option D, the meningococcal conjugate vaccine, is a conjugate vaccine. It links bacterial polysaccharides to a protein carrier to enhance the immune response. This type of vaccine is particularly effective in infants and young children and is also safe for immunocompromised individuals. For NCLEX, always associate live attenuated vaccines with stronger but more restricted use. They are not suitable for pregnant individuals or clients with weakened immune systems. Recognizing the differences between live attenuated, inactivated, recombinant, and conjugate vaccines is crucial for selecting safe and effective immunizations for each client population. Let us now reinforce your understanding of vaccine classifications with a scenario that puts your training to the test. This next question is about correctly identifying the nature of different vaccines, especially live attenuated types, an area that often appears on the NCLEX. So here is question number 10. The nurse has recently completed an immunization training session. Which of the following statements by the nurse indicates a correct understanding of vaccine classifications? Pay close attention to the phrasing of each statement because one of them reflects textbook accuracy. Here are your options. Option A, the measles, mumps, and rubella vaccine contains a weakened form of the virus and is categorized as live attenuated. Option B, the hepatitis B vaccine is considered a live vaccine because it uses viral components. Option C, live vaccines are recommended during pregnancy to help protect the fetus. Option D, the influenza shot and the intranasal flu spray are both live attenuated vaccines. The correct answer is Option A, the measles, mumps, and rubella vaccine contains a weakened form of the virus and is categorized as live attenuated. Now here is why that is the most accurate statement. The measles, mumps, and rubella vaccine is indeed a live attenuated vaccine. That means it contains a weakened but live form of the virus that stimulates a strong immune response while being safe for immunocompetent individuals. This type of vaccine tends to offer long-lasting protection with just 1 or 2 doses. However, due to the presence of live virus, it is contraindicated in individuals who are pregnant or severely immunocompromised. Now, let us explore why the other statements are incorrect. Option B is wrong because the hepatitis B vaccine is not live. It is a recombinant vaccine. It is made using genetically engineered viral proteins and contains no live components at all, which makes it safe for newborns, immunocompromised individuals, and pregnant clients. Option C is also incorrect. Live vaccines are never recommended during pregnancy because of the theoretical risk of transmitting the virus to the fetus. Vaccines such as the measles, mumps, and rubella vaccine, varicella vaccine, intranasal influenza vaccine, and live zoster vaccine are avoided during pregnancy. Instead, inactivated vaccines such as the tetanus, diphtheria, and a cellular pertussis vaccine and the inactivated influenza vaccine are preferred during pregnancy. Option D is misleading and incorrect. The intranasal flu spray is a live attenuated vaccine, but the standard influenza injection, known as the flu shot, is inactivated. This distinction is very important, especially when caring for clients who are pregnant or immunosuppressed, as only the inactivated version is safe for them. For NCLEX, always associate live attenuated vaccines with strong, durable immunity, but limited use in vulnerable populations. Key examples include the measles, mumps, and rubella vaccine, varicella vaccine, rotavirus vaccine, intranasal influenza vaccine, yellow fever vaccine, and smallpox vaccine. In contrast, inactivated and recombinant vaccines are much safer for high-risk groups and are more commonly used when safety is a primary concern. This type of classification question is high yield and requires both clinical knowledge and careful reading of the options. Let us now talk about one of the most powerful yet often under-recognized benefits of vaccination: cancer prevention. This next question highlights how nurses can educate others on the role vaccines play, not just in preventing infections, but in actually lowering the risk of developing certain cancers. So here comes question number 11. The nurse is organizing a staff development conference focused on vaccine-preventable diseases. Which of the following statements should the nurse include to emphasize the role of vaccines in cancer prevention? Think carefully here, because only one of these vaccines is directly linked to reducing cancer risk. Here are your options. Option A, the hepatitis. A vaccine prevents cervical cancer linked to viral exposure. Option B, the human papillomavirus vaccine helps reduce the risk of developing cervical cancer. Option C, the varicella vaccine eliminates the risk of genital herpes and related complications. Option D, the influenza vaccine is contraindicated in clients with a family history of cancer. The correct answer is option B, the human papillomavirus vaccine helps reduce the risk of developing cervical cancer. Let us walk through why that is the best choice. The human papillomavirus vaccine is currently the only vaccine proven to prevent certain types of cancer. It protects against high-risk strains of the human papillomavirus, especially types 16 and 18, which are responsible for the majority of cervical cancer cases. In addition to cervical cancer, it also helps prevent other human papillomavirus-related cancers, including vaginal, vulvar, penile, anal, and oropharyngeal cancers. The vaccine is routinely recommended for both males and females at age 11 to 12, though it can be started as early as age 9. Catch-up vaccination is advised through age 26 for those who missed it earlier. Now let us explore why the other options are incorrect. Option A, the hepatitis. A vaccine is effective at preventing acute viral hepatitis A, which is a liver infection transmitted through contaminated food or water. However, it has no role in preventing cancer, especially not cervical cancer. Option C, the varicella vaccine, protects against chickenpox caused by the varicella zoster virus. It does not offer any protection against genital herpes, which is caused by herpes simplex virus type 2. These viruses are unrelated despite the similarity in names. Option D, the influenza vaccine is not only safe for individuals with a family history of cancer, it is highly recommended. Clients undergoing or recovering from cancer treatment often have weakened immune systems and are at increased risk of severe influenza-related complications. So, annual vaccination is vital. For NCLEX, always associate the human papillomavirus vaccine with cancer prevention. It is a major advancement in preventive health and a perfect example of how nurses can advocate for long-term wellness through immunization. Understanding vaccine indications beyond infection control, like cancer risk reduction, will help you stand out in both exams and patient education. Now, let us dive into another high-impact vaccine that plays a powerful role in long-term cancer prevention: the human papillomavirus vaccine. This next question focuses on timing, because the age at which the vaccine is given determines how effective it will be in protecting against serious human papillomavirus-related diseases. So here comes question number 12. The nurse is providing vaccine education to a parent about the human papillomavirus vaccine. For which group is this vaccine routinely recommended to provide the most effective protection against human papillomavirus-related diseases? Think carefully about when the immune response is strongest and exposure is least likely. Here are your options. Option A, adolescents aged 11 to 12 years. Option B, newborns during the first week of life. Option C, adults over the age of 50 with a history of genital warts. Option D, pregnant clients in their third trimester. The correct answer is option A, adolescents aged 11 to 12 years. Now let us explore why this is the most effective timing for vaccination. The human papillomavirus vaccine is routinely recommended for preteens aged 11 to 12 years, though it can be started as early as age 9. This is because the goal is to complete the vaccine series before any potential exposure to the virus, which is typically transmitted through sexual contact. When the vaccine is started before the age of 15, only 2 doses are needed. If the series is initiated at age 15 or older, 3 doses are required to ensure adequate immunity. The vaccine protects against the most high-risk human papillomavirus strains, types 16 and 18, which are responsible for the majority of cervical cancers, as well as cancers of the vulva, vagina, anus, penis, and throat, along with protection against genital warts. Now let us look at why the other options are incorrect. Option B, newborns do not receive this vaccine, as it serves no purpose at that age and has not been studied in infants. Human papillomavirus is not a concern during the neonatal period, and vaccination is not effective or appropriate until pre-adolescence. Option C, adults over 50 with a history of genital warts are not the target group for routine vaccination. While individuals between the ages of 27 and 45 may discuss vaccination with their healthcare provider, it is not routinely recommended after age 26. Also, the vaccine has no therapeutic effect. It does not treat existing infections or warts. Option D, the vaccine is not recommended during pregnancy. Although there is no evidence of harm if given inadvertently, the series should be paused and resumed postpartum to ensure safety. For NCLEX success, always associate the human papillomavirus vaccine with ages 11 to 12 for routine protection. Early vaccination ensures the immune system has time to build strong protective antibodies before any exposure occurs. Remember, the human papillomavirus vaccine is preventive, not curative, and should be given well before the risk of transmission begins. Let's take a quick moment before we begin. Are you confident about passing the NCLEX? If not, don't worry. The complete NCLEX Review online course gives you 100 hours of animations, 500 hours of recorded lectures, 5,000 practice questions, 500 NGN-style case studies, and 15 mock exams just like the real test. You'll also get an ebook and 1 year of full access. Enroll now and get 70% off, only for a short time. Head to the link in the description and start your success journey. As we pivot from pediatric and adolescent vaccines to adult care, it is time to talk about something every nurse must prioritize: protecting our elderly clients with chronic diseases from preventable infections. This next scenario highlights exactly how comorbidities like heart and lung disease influence vaccine decisions in older adults. Welcome to question number 13. The nurse is assessing a 75-year-old client with a history of coronary artery disease and chronic obstructive pulmonary disease. Based on the client's age and underlying conditions, which immunization should the nurse prioritize recommending? Think about which vaccine offers the strongest protection for someone with both advanced age and chronic illness. Here are your options. Option A, pneumococcal vaccine. Option B, varicella vaccine. Option C, rotavirus vaccine. Option D, hepatitis A vaccine. The correct answer is option A, pneumococcal vaccine. Let me walk you through the reasoning. Adults age 65 and older are already at increased risk for pneumococcal disease. And when you add underlying heart and lung conditions like coronary artery disease and chronic obstructive pulmonary disease, that risk becomes significantly higher. Pneumococcal vaccines protect against invasive illnesses such as pneumonia, meningitis, and bloodstream infections, conditions that could be fatal in this client population. The current recommendations include conjugate versions such as pneumococcal conjugate vaccine 15 or pneumococcal conjugate vaccine 20, with the possibility of following up with pneumococcal polysaccharide vaccine depending on the client's prior immunization history. Now, why are the other options not appropriate here? Option B, the varicella vaccine, is for chickenpox prevention and used in childhood. For adults over 50, the correct preventive strategy would be the recombinant zoster vaccine to prevent shingles, not the varicella vaccine. Option C, the rotavirus vaccine, is only given to infants to protect against viral diarrhea. It is never used in adults and certainly not in elderly clients. Option D, the hepatitis A vaccine, is given based on specific risk factors like chronic liver disease or international travel. It is not a routine recommendation for older adults unless clearly indicated by the client's lifestyle or health status. For NCLEX, this kind of question tests your ability to match age, risk factors, and vaccine type accurately. Remember, the pneumococcal vaccine is a priority for anyone over 65, and especially those with chronic conditions like coronary artery disease and chronic obstructive pulmonary disease. It is a key part of preventing serious respiratory infections in vulnerable populations. To bring everything full circle, we are wrapping up our vaccine review series with one final question that ties together all the knowledge you have gained about vaccine classifications. This is the kind of question that really challenges your understanding of how different vaccines work at a molecular level. A must-know for both safe nursing practice and NCLEX success. So here comes question number 14. The nurse is attending a continuing education session about vaccine classifications. Which of the following statements made by the nurse reflects a correct understanding of the content? Read carefully and watch for key phrases that reveal whether the nurse is describing the vaccine's mechanism correctly. Here are your choices. Option A. The COVID-19 messenger ribonucleic acid vaccine contains a weakened form of the coronavirus. Option B. The hepatitis B vaccine works by inactivating the live virus in the bloodstream. Option C. The rotavirus vaccine is classified as a live attenuated vaccine. Option D. The diphtheria vaccine contains live bacterial components to stimulate immunity. The correct answer is option C. The rotavirus vaccine is classified as a live attenuated vaccine. Here's why this statement is the most accurate. The rotavirus vaccine is given orally to infants and uses a weakened form of the live virus that replicates only in the gastrointestinal tract. This replication is enough to trigger an immune response, helping the infant build strong immunity to a virus that causes severe diarrhea and dehydration in early childhood. It is part of the routine immunization series for infants, and like all live attenuated vaccines, it is not recommended for immunocompromised clients or during pregnancy. Now, let us examine why the other options are incorrect. Option A, the COVID-19 messenger ribonucleic acid vaccine, such as those produced by Pfizer, BioNTech, and Moderna, does not contain live virus at all. Instead, it contains genetic instructions that tell the body's cells to produce a harmless version of the spike protein, which prompts the immune system to respond. There is no weakened or inactivated virus involved. Option B, the hepatitis B vaccine, is a recombinant vaccine. It contains a surface protein of the hepatitis B virus made through genetic engineering, which stimulates the immune system without the virus ever being present in the bloodstream, live, or otherwise. Option D, the diphtheria vaccine, is a toxoid vaccine. This means it contains an inactivated form of the toxin produced by the diphtheria bacterium, not the bacteria itself. It trains the immune system to neutralize the toxin rather than to attack the bacteria directly. For NCLEX, understanding these classifications, live attenuated, inactivated, toxoid, recombinant, and messenger ribonucleic acid, is essential. They determine how a vaccine works, who it is safe for, and what risks it may pose. Rotavirus, like measles, mumps, rubella, varicella, and yellow fever vaccines, falls under the live attenuated category. Knowing these distinctions will help you safely administer vaccines, educate clients accurately, and confidently answer immunization questions on the exam. And that brings us to the end of today's high-impact session on pharmacology of immunizations. But your NCLEX journey does not stop here. We will be back very soon with another must-watch video packed with the kind of questions and concepts that show up on the real exam. If you found today's content helpful, then get excited, because we drop new videos every single day, covering the most important, high-yield topics that you absolutely need to know to pass the NCLEX. From test strategies to critical thinking skills, we break it all down in a way that makes it stick. So do not just watch. Make this your daily NCLEX habit. Hit that follow button, stay consistent, and let us help you reach your goal of becoming a licensed nurse faster and smarter. Your success is our mission. See you in the next video.